Did you know that the blue circle is the official symbol for diabetes? Neither did I. Today we're going to talk about pediatric DKA and talk a little bit about diabetes in the meantime. So we know that there are basically three types of diabetes: type 1, type 2, and gestational diabetes. Type 1, or previously called juvenile onset diabetes, is one in which the pancreas does not make insulin. Type 2, or insulin-resistant diabetes, is one in which the cells don't respond to insulin, and gestational diabetes basically happens in pregnancy. And today, though, we are looking at pediatric patients. And so in 2010, there were 215,000 patients diagnosed with diabetes mellitus under the age of 20 years. And this is going to continue to rise as our pediatric patient continues to increase in weight. And of these patients, about from 12 to 80%, so that's a pretty big range, present for their first time with DKA, including about 5 to 25% of pediatric patients who show up with type 2 diabetes. Now, some of the risk factors for having pediatric DKA are younger patients, poorer patients, and those without good health care. So now let's just take a quick look at how things normally work. And here I have a picture of the liver, and the liver is where gluconeogenesis happens, and glucose is released and that is inhibited by insulin, which is released from the pancreas and the islets of Langerhans. It's the beta cells in there that are the ones that create the insulin. So let's take a look at that. So what happens here is glucose will enter one of these islet cells and through cellular respiration create ATP. This ATP actually inhibits a potassium channel, and this potassium channel normally causes a depolarization as it lets potassium out. And that depolarization inhibits these voltage-gated calcium channels. So by having glucose here inhibiting this, which inhibits this, what we're actually getting is calcium to flow in, and that allows insulin to be released from the intracellular storage. Then the insulin that is released from the pancreas actually works to inhibit the gluconeogenesis that's here. And so it prevents glucose from being released into the bloodstream, which makes sense because we already have excess glucose. We don't want to release our glucose stores. Now what we can see here is that there are other hormones actually that will cause gluconeogenesis to happen, and these are the counter-regulatory hormones of glucagon, epinephrine, cortisol, and growth hormones. And these can be released in times of stress. And again, that makes sense too, because in a time of stress, you do need to have extra glucose floating around. There are certain medications as well that can increase glucose in the bloodstream: steroids, atypical antipsychotics, and immunosuppressants. And DKA results when we have an imbalance between insulin and the counter-regulatory hormones. So this means that we would have either a decrease in the amount of insulin or an increase in the counter-regulatory hormones, which then leads to one of three, or all three of these things happening: increased glucose, increased ketones, and an acidosis. And so an increased glucose, usually above 200 milligrams per deciliter, increased ketones, and we'll talk about that in a second, and acidosis. And you can look at that two ways, either through the pH or through the bicarb level. And so pH less than 7.3 for mild, 7.2 for moderate, 7.1 for severe, or bicarb of less than 15. And back to these hormones here, you can either have an absolute insulin deficiency when you just have no insulin, such as in the type 1 diabetics, or a relative insulin deficiency where you just have so much counter-regulatory hormones that there's just not enough insulin to balance this out. So one way to think of this balance is to think of insulin as the good times hormone and the counter-regulatory hormones as the stressful times hormones. So in good times, you got plenty of food to eat, things are going well, you got glucose floating around, you can store that away, you store it in muscle. Now, in stressful times, you have someone's chasing you, whatever, you need some more energy, so you need to release glucose, so you have gluconeogenesis. And then that's when you have glucose that's released. Now, other things also happen during these times. You can get more glucose from other places. You can have proteolysis. So as proteins break down, that can eventually be turned into glucose. And also lipolysis. As fat breaks down, it can really, break down into fatty acids, which then can be converted to acetyl-CoA, and in the Krebs cycle can eventually turn into glucose. However, you need insulin around for this part to happen. So instead what happens is these fatty acids get shunted into forming ketones. And the ketones that we typically think about are acetoacetate, beta-hydroxybutyrate, and acetone. Now, acetoacetate and beta-hydroxybutyrate are acids. They're weak acids, but they're acids nonetheless. But there's just so much of it that's produced that it overwhelms our buffering capacity. And so you get these acids here that form. Now, acetone actually is not as much of an acid. It doesn't dissociate, but it's metabolized through the lungs and then breathed out. And then that's when you smell that fruity odor. Now let's have a word or two about these ketones here. So when we measure ketones, the normal tests will measure through the nitroprusside reaction. It'll only measure acetoacetate and acetone, but not beta-hydroxybutyrate. Beta-hydroxybutyrate is the one that is in greater amounts. It's 10 times the amount than acetoacetate. Now, there is a test for beta-hydroxybutyrate, so it can be measured, though we usually don't. The levels for this tend to drop more quickly than acetoacetate and are a better indicator of improvement of symptoms. So some people actually recommend following beta-hydroxybutyrate levels in order to determine when that gets normal. That's when you need to stop treating the DKA. And as these acids build up, you're going to get a metabolic acidosis, and the body compensates through increasing ventilation, and then you get the typical Kussmaul respirations, which is the deep breathing that you see diabetics have. So when we are in times of stress, we're going to start forming these ketones and acidosis, and this is kind of how it happens. So one of the hallmarks of diabetes, DKA, is the dehydration that happens. And so you have this huge glucose load outside the cell, which acts as an osmotic force that pulls extracellular water out and into the extracellular space. And then that is ultimately lost through the kidneys through an osmotic diuresis, with the glucose coming out, pulling water with it, and even pulling potassium with it as well. And that could create a pretty profound volume depletion. And that volume depletion activates the renin-angiotensin system, which leads to even more loss of potassium. Which brings us to what's happening with the potassium. So we already know that we're losing it through our osmotic diuresis. And all the ketones act as a potent emetic, which also causes loss of potassium. All of this leads to a hypokalemia. Now, the acidosis that we have activates the hydrogen-potassium exchange pump, pumping potassium out of the cell, which can make it look like the patient is actually hyperkalemic, even though they have a total body depletion of potassium. Pretty confusing. So obviously we need to keep a close eye on the potassium. Now let's look at sodium. So the glucose kind of dilutes out the sodium. So what you will see when you measure it is the patients will appear hypoglycemic. However, that's not actually the case, so you need to correct for this. So to do that, you take the sodium measured and you add 1.6 for every glucose over 100 divided by 100. So glucose minus 100 over 100 times 1.6. And this number may, some people actually say use 2.4, but 1.6 is what we got here. Now, and that gives you the actual sodium. Now, when you're calculating the anion gap, you need to use actually the measured sodium. So you don't use that corrected version. So this video looked kind of at the pathophysiology of DKA. And in the next one, let's look at the treatment of pediatric DKA. Thanks.